Hey, it's Rob Fitzgerald again. Glad to be back talking about laboratory diagnosis of GI disease. Many patients suffer from gastroesophageal reflux disease, too much acid in their stomach, and so we're going to talk a little bit about that. We're going to talk about malabsorption and maldigestion. Malabsorption would be sort of characteristic of cystic fibrosis, of Crohn's disease, of celiac disease, whereas maldigestion really is the inability to break down things, typically associated with carbohydrates and disaccharides. We're going to talk about the laboratory test for diagnosing Helicobacter pylori infections. H. pylori is responsible for a significant amount of GERD, and the pharmaceutical companies had an ideal drug in the proton pump inhibitors because they completely treated symptoms and did nothing about the causative factor. And so now we know that an infection also causes GERD. We can actually treat the infection as well as the symptoms. And so we'll talk about some of the tests for diagnosing H. pylori. We'll talk a little bit about the Shilling's test for B12. B12 deficiency causes a megaloblastic anemia, which means you have big red cells, but not many of them. And so you would look at their MCV, or their mean corpuscular volume, and it would be elevated and they would be anemic. And so a variety of tests for that we'll talk about. Talk a little bit about the diagnostic approach for celiac disease, a really interesting mechanism for administering drugs, iontophoresis. And then we'll talk about how we do sweat collection for, sorry, I mixed that up. Cystic fibrosis is diagnosed by the iontophoresis. Celiac disease is diagnosed based on really eliminating gluten from the diet or doing a biopsy and having an anatomic pathologist look at the biopsy. So GERD is one of the most common disorders of the esophagus, maybe 10% of the population. So a huge number of patients have problems with peptic ulcer disease and associated things. If they have severe peptic ulcer disease, they will often get a biopsy, and sometimes we measure pHs, especially if they're failing proton pump inhibitors, because we can actually look at the acid content and they might have something else going on. Helicobacter pylori, diagnostically, historically it's been a biopsy and a culture. And the culture, what they're actually looking for is urease activity, and we'll see why the urease actually changes the local pH, and that can be picked up on plates and is useful when doing biopsies. It can also be diagnosed by breath test, and C13, we like to use C13 as opposed to C14 because C13 is a stable isotope. It can be measured by NMR, it can be measured by mass spectrometry, and we simply give a dose of urea with C13 in it, and we're trying to see how much urea is excreted in breath. And we'll cover that in a little bit more detail in a second. So a positive test indicates active disease, and that's as opposed to immunoassays. And so this is a really important distinction. A breath test tells you active disease, whereas an immunoglobulin test tells you prior exposure and not necessarily active disease. So you could put someone on quadruple therapy, cure their H. pylori infection. Their C13 breath test is going to be negative following a cure, whereas their immunoglobulins are still going to be present and will be detected. So an immunoassay just tells you a past infection. This is sort of the theory behind a urea breath test, and so we've got urea drawn here. We talked about that in the setting of renal disease. Urease cleaves urea into CO2 and to ammonia molecules. These ammonia molecules are what allows the bacteria to live in the superacidic environment of the stomach. pH of stomach contents is 1 to 2, and so most things don't live there at that acidic concentration. And so the way that H. pylori functions is that it generates its own little microcosm where it increases the pH by generating urea, generating ammonia from urea using urease. We take advantage of that in the laboratory, and in this case, instead of having just urea, we administer C13 urea. So this is carbon-labeled urea, and the urease, if it's active, is going to cleave it into C13 CO2, which we can measure specifically using either NMR or mass spectrometry. And so basically what we're looking for is, in the cases of active disease, you're going to have urease, and patients are going to expire through their breath C13 containing urea as opposed to regular carbon-12 urea. One of the benefits of doing a C13 breath test is that it pretty much coats the entire stomach and gives you an assessment of urease activity in the entire stomach, whereas a biopsy has to be done on the correct spot in the stomach containing the H. pylori infection. And obviously a breath test is a lot less invasive than a biopsy. So maldigestion is the inability to break down certain things, which causes GI distress, and diarrhea is a very common finding in this setting. So there's a digestive dysfunction versus malabsorption. It's really a dysfunction of the gut, and it could be caused by an immune response to gluten or Crohn's disease or something like that. And so diagnostically, we're going to demonstrate the presence of malabsorption. So both of these cause malabsorption. One also has a problem with breaking down substances. We're trying to identify which process is taking place. So if you have a patient who has diarrhea, these are some common lab findings. They're not absorbing their calcium. They're probably not absorbing vitamin D. If they're not absorbing calcium and their serum calcium is low, then their alkaline phosphatase is elevated because your parathyroid reacts and increases PTH, which is going to break down a bone, releasing calcium and alkaline phosphatase. Urea nitrogen is typically low because you're not absorbing it. They're hypocholesterolemia because they're not absorbing cholesterol. Prothrombin times typically go up. They go up because you're not absorbing vitamin K. And glucose tolerance curves are typically flat. So you give glucose, but you don't see the normal rise. Test for malabsorption. So thinking about carbohydrate malabsorption, one of the ways to do that is d-xylose. So d-xylose is a 5-carbon sugar that's not metabolized. You don't utilize it. And so you give that orally, and you measure it in the bloodstream. If it's being absorbed, then that sort of helps rule out malabsorption of carbohydrates. If you have a carbohydrate malabsorption issue, then once you give it orally, you won't see it in the bloodstream. Sort of makes sense. A disaccharide test, and so if you're galactose intolerant, or basically you give the disaccharide and you measure glucose, because glucose is present in the disaccharides, and you're expecting to see an increase of the glucose. If you don't, then you can you can further pursue the pathway of having a disaccharide deficiency. So that was typically a genetic deficiency in the inability to break down certain sucrose or glucose or fructose. A breath hydrogen test. Typically, mammalian cells don't generate hydrogen, whereas bacteria do. And so you can get carbohydrate malabsorption due to bacterial overgrowth, and in that case, you would have an elevation of your breath hydrogen test. Fat malabsorption occurs, and one of the ways we can identify that is fecal fat. And so, not one of our favorite lab tests. It requires typically 3 days of collecting feces and then measuring the amount of fat in the fecal material. Another way to do that maybe a little bit more pleasant way, is to give C14 labeled triolein, which is a fat that contains a radio label. It's a small dose of radiation, and basically you measure that in breath. If they're absorbing it, then they're metabolizing it, and you're going to excrete out the C14. If not, then you will have a low amount of C14 in the breath. Bacterial overgrowth, a C14 xylose breath test. So again, d-xylose, we don't typically metabolize it in mammalian cells, but if you have bacterial overgrowth, then the bacteria will metabolize the xylose, and you will get an increase of CO2 containing C14. Others are the Shilling's test that we're going to talk about, the sweat test for cystic fibrosis. So celiac disease is a very common disease due to gluten insensitivity. Gluten in the diet causes an immune response, which causes malabsorption. Varying degrees of severity, and at least 1% of the population has celiac disease. We have good lab tests for celiac disease. There are a couple of requirements, though. One is that they have to have gluten in their diet at the time you do the laboratory test. And the most sensitive test is an IgA, so it's an immunoglobulin, it's an IgA against endomysial antibodies. So it's a very sensitive and a reasonably specific test. If they're positive, sometimes they'll do a biopsy of the bowel, and they're looking for characteristic findings of celiac disease. You would confirm that by putting them on a gluten-free diet. Sounds easy, but is not. And if they lose their malabsorption in the absence of gluten, then that sort of confirms the diagnosis. One of the problems with doing an IgA endomysial antibody test is about 2% of the population is IgA deficient. And so you can easily test IgA deficiency by just measuring total IgA. If they have a deficiency in total IgA, then you might want to do an IgG endomysial antibody test. Vitamin B12 deficiency is the cause of pernicious anemia, and you can measure vitamin B12 directly with an immunoassay. And immunoassays typically are okay, but at the low end, which is really where you need them to work, they don't work so well. So there's other ways to address B12 deficiencies, and one of those is methylmalonic acid. Methylmalonic acid is converted into succinic acid in the presence of B12. So if you have a B12 deficiency, your methylmalonic acid goes up, and that's a functional readback of your B12. And so, as I said, some people would prefer methylmalonic acid as to measuring, B12 directly. Autoantibodies against intrinsic factor are also measured. Intrinsic factor is a requirement for absorption of B12. So if you have antibodies against intrinsic factor, it can't bind the B12 and you become B12 deficient. Has also been diagnosed with a Shilling's test. And the Shilling test, the basic principle of that is you give a radio-labeled B12. And the radio label, if you absorb it, it's going to go into your bloodstream, and from your bloodstream it's going to get into your urine, and you're going to excrete it into the urine. So if you don't have pernicious anemia, you absorb B12 and you excrete more than 8% of the radio label in the urine specimen. If you have a problem absorbing B12, it stays in your gut and you excrete it in your feces. It never shows up in your urine, and so that would be a positive Shilling test indicating, pernicious anemia. So it's cobalt labeled with 57 cobalt. It's a radioactive dose, and you can monitor that. And as I said, greater than 8% in urine rules out pernicious anemia. Last couple of tests I wanted to talk about were cystic fibrosis. Cystic fibrosis is diagnosed with a sweat test, and from a pharmacological perspective, it's an interesting test. You administer pilocarpine, which is a cholinergic muscarinic agonist, which is going to induce sweating. It's a tertiary amine, so if you put a charge up against it, the charge actually sends it into the skin, and then subjects start to perspire. And so you collect the sweat and you measure the sweat chloride content. And so the sweat chloride content is going to be indicative of cystic fibrosis. So a high chloride content is consistent with CF. Last test I want to talk about is fecal occult blood. Fecal occult blood is looking for GI bleeds. If you have a massive GI bleed, and it's towards the end of the GI system, patients will have bright red feces because of the blood, and that's fairly easy to pick up. Whereas what we're talking about here is hemoglobin, so bleeds sufficiently small that you cannot be seen. So that's why we call it occult, and we look at it in feces, so they're fecal occult blood tests. Typically, these are cancer screens. That's primarily what's being done with a fecal occult blood. Historically, they were done by a guaiac. It was an oxidation, it was a redox reaction, and it was subject to false positives. And so special diets, you couldn't eat meat, you couldn't eat specific vegetables because they could cause false positives, and vitamin C caused false negatives. So there's problems with the initial test. We now do it by an immunoassay, and it's actually very sensitive. It's more sensitive than the guaiac test, and sensitive to like 50 nanograms per mil of hemoglobin in a fecal sample, so it's quite sensitive. So that sums up our diagnosis of GI diseases, and I appreciate you tuning in.